the chair of the department and as the person who really leads the charge strategically for us, where do you see the future of transplantation at VCU, and including, of course, pediatric transplantation?
We have significant opportunities to expand into the area of lung transplantation and maybe into other forms of transplant that are not still common but are of great importance to us. For example, is like an abdominal wall transplant. We have a very large complex traumas program with a significant number of patients with abdominal wall loss after multiple operations or after trauma that could benefit from abdominal wall transplantation. And also vascularized grafts such as hands could be a potential growth area for us. The next step for us is to actually take some of the patients who have a cardiac arrest and then donate livers and kidneys and support them with circulation using a heart-lung machine to see if we could actually resuscitate the heart in the body itself. Particularly with the artificial heart technology, there is a new device that's going to soon come to market. We're looking to start a clinical trial in the US. It's a fully implantable artificial heart that's electrically powered. The advantage of that heart would be that you don't need immunosuppressive therapy. So for example, for somebody who's older, who has pre-existing kidney disease that could be compromised by giving them drugs to modify their immune system, an artificial heart would provide a good alternative if it's quiet and it's fully internalized. We recently got a large, very generous grant from two grateful patients of ours, the Cottrells. And with that, our hope is to completely redo our lab space in Sanger to build an organ reanimation facility. The first step of that would be to expand what the work Dr. Mangino is doing in the lab, looking at various fluids that are used to perfuse organs and keep them alive and preserve them. The next step would be to actually take organs and study human organs and study them and see if they could be utilized for transplantation safely. So this would be very exciting, and I think the next 4 or 5 years would be very important for us.
You know, what I think is incredibly exciting about the technology that's emerging, both the work that Dr. Mangino is doing in his lab and also what device manufacturers are doing is really the ability to keep an organ outside the body, in between the donor and the recipient, for a longer period of time. And also to, if you will, expand the donor pool. Let us, as clinicians, go after hearts or livers that perhaps we wouldn't have considered, or give time to resuscitate these organs so that when they're transplanted, they function better and perhaps lead to a shorter hospital stay, fewer complications for the recipient, ultimately decrease the expenditure that transplantation can mean for the health system.
The other critical piece for us from the heart side is still, in spite of all the advances, our total ischemic time, or the time that the heart can stay out of the body, is limited to about 3-4 hours at the maximum. So right now, we cannot match hearts based on the genome, and we simply just use blood type. So you may have a perfect match on a heart in San Diego to somebody in Richmond, but we won't be able to utilize the heart because the times are too long.
It's too far away.
Too far.
So one of the things that we've done in the last year or so is really to leverage the robotic technology that's existing and is really bountiful at VCU. So a surgical robot that lets us surgeons, as you know, approach operations with smaller incisions, with quicker recovery time, with perhaps more precision as we do the work intra-abdominally or intrathoracically. So we've moved to completely robotic live donor nephrectomy for our live donor kidney transplants, and I think are really on the cusp, having done some laboratory work, to be able to use a robot to implant kidneys as well, which I think is really quite exciting. It would bring the same advantages that we have with shorter lengths of stay, smaller incisions, quicker recovery time, bring that to the recipient of the kidney transplant as well as where it is now with the donor. One of the joys for me to be able to come to VCU and to a true academic environment is the thirst for knowledge and the joy at discovery that not just the transplant team, but every colleague that we interact with in the School of Medicine, in the School of Engineering, there's an abundance of resources and of fertile minds for us to tap into and to really create the next frontiers in our world, which is in transplantation.